Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei Podcast. It is my great pleasure to introduce Dr. Farouc Jaffer, great interventionalist and a great friend who is the Director of Interventions and CTOPCI at the Mass General Hospital in Boston and Associate Professor of Medicine at Harvard Medical School. Farouc, welcome, and again thanks for taking the time today for joining us in the Sensei Podcast.
So great to be here, Manos, and thank you so much for the invite.
No, thank you, and congratulations on having built one of the premier CTO programs in the US and the world. And maybe we can always start by discussing how this came to you. I know you are in a very research-oriented facility. Yourself have a lot of NIH funding, a lot of high-end research projects. How did CTOPCI come to you, which typically is not done by people in the research area?
Thanks for asking that. It's a really neat question to reflect on. And when we first got into it, we did face some skepticism because, I was a research guy, and I started this in partnership with Bobby Ye, who, of course, who's now at the BI. But we started this together, and he was also in a research environment. And so the initial comments were like, well, why are two research guys doing, some of the hardest procedures out there? And, what I learned from that, of course, is, people sometimes have kind of an incorrect association or appreciation. I think we were really well suited. I was really well suited for this because it is a multi-step process where the exact outcome is not known ahead of time, how one is going to solve it. Of course, that's why one loves it from a technical standpoint. And being a scientist, as part of my other life, it forces you to have a range of hypotheses, a range of backup plans and alternative explanations, and working through a series of steps methodically, and being willing to deal with setbacks and frustration. You learn that because your experiments don't work your entire life, so you're used to failure. And that sets you up for resilience in a field such as CTOPCI, where it's really needed. Again, there are going to be times where you're not going to be able to succeed and need to have a mental balance and a perspective to be able to approach that.
But the criticism usually is that, based on the research, do you have enough time? Because CTO can be time-consuming and difficult to do. So how did you manage that? How did you manage to balance the research agenda and the CTO procedural time?
Really, really great. So in the very beginning, I started on staff in 2003, and my first focus was to really build the experimental lab. And that really was a 2/3, 3/4 effort. So I was in the cath lab 2 days a week doing kind of standard, PCI from simple to complex, things that were inpatient. And I was there, and my focus was really building the science lab. That took about 7 or 8 years before I received my first R01. And, during those 7 or 8 years, I had always been interested in CTOPCI because I saw how technically different it was compared to regular PCI, and had the chance to watch a few of the retrograde cases that were coming out in the mid-2000s from Japan, and my jaw just dropped when I saw how an RCA was reconstructed retrograde. I just said, I used to tell people, I said, if there was a Nobel Prize for interventional cardiology, the Japanese to go through the septals retrograde to consider reverse cart would be in the top 5 for sure. And when I saw that, I was absolutely, stunned and excited and motivated because, we of course are driven clinically to try to get improved outcomes for our patients. And so I started doing the first kind of bilateral access cases at MGH in the early 2000s, really trying to help us understand how to do better antegrade wire work. And then I took a few sparse courses. I went down to visit Greg Stone at Columbia when he had also some of the Japanese senseis come over, and just were starting to watch how they were approaching retrograde. But really that was a light experience until 2010, after I got my R01 and I had my lab in place, the next step was really the evolution of the Bridgepoint Stingray ADR work and the consensus group that, of course, you were part of and led us to understand how the hybrid approach might be applied. So in 2010, 2011 is when I really started devoting much more time towards building a structured program. And because the lab was mature and because I was actually otherwise only in the cath lab 2 days a week, I actually had time to do extra days in the lab, as did Bobby. And that allowed us to really have those dedicated times to co-scrub and do these harder, longer cases together.
Perfect. That reminds me actually of Simon Walsh and Colm Hundred. They're very similar situation where they scrub together in they still do many of those cases. So how did that? Obviously, Bob is a phenomenal person. You're phenomenal. How did you work it out? How did you arrange who does what? Learn from each other. How did this all pan out?
Yeah, I think it was really a blessing that both of us were really interested in this, and Bobby, of course, is a superb human being and really great clinical scientist and just thoughtful guy. So we had a lot of similar personality traits in terms of our approach to methodology and science, and having this technical interest. I think as we got into this program and started really listening to our leaders and mentors, you being in that group, recognizing the importance of partnership, we realized we had to figure out a way to work together. There hadn't really been that precedent in interventional coronary intervention. I think most coronary interventionalists were trained to believe that they were an island and kind of the last resort and would do everything independently, and that was the way that one was judged or perceived. And it really took us understanding that these were new skills that we were going to have to learn. Both of us were going to have our hands on new gears, try different things. So we basically would alternate, someone being front operator, someone being assistant operator. And in certain parts of the case that were sensitive, surfing, removing microcatheters, knuckling, we would both try to do parts of those cases almost for every case, but recognize that someone was going to be the lead for that and we were going to support them during that time. And we just tag team. And that was really the best way to do it.
And then how long did I know Bobby moved to Beth Israel eventually, but how did you change afterwards, since now you didn't have Bobby? I guess now you have other.
Well, it was definitely a step up to have to do it, but most of our operators and programs, people of course function independently, and those the first year or two was definitely different. I think I had to realize what I needed to do to increase efficiency and build the infrastructure further. And we engaged a formal technical and nursing expert group in that time frame that could also really focus on making sure that things that could go well efficiently did, from both the clinical nursing side and the technical equipment side, and actually having some of those scrub technicians scrub in with us to do some of those cases also, because they knew the strategy more than the interventional fellows who were in their first year just coming into their procedures. So that's how we had to build it. And I think, reaching out to other folks, to discuss complications or strategies, I definitely did that more once Bobby had stepped away. And I think that was great to feel like we had, I had a community of people who could advise. You were one of those folks. And I remember you very, very dearly sending me a modified PowerPoint with where you would plan your base and how we should knuckle here, and that was, those are some of the things that were really a dear part of the community.
And then how did you teach your team, the techs and the nurses? Do you have the same people who do the complex case with you, or they're rotating right now?
Yeah, so we had 2 lead technologists and 2 lead nurses, and in the 2016, 17, 18 era, they would try to scrub more heavily, and it was particularly important in Q1 and Q2 of the interventional fellow year. After that point, the interventional fellows really had a good sense of what was going on, and our scrub techs could be kind of freed up to do other things. But yes, I mean, having them, even the way that we get access had changed, right, with micropuncture and ultrasound, and integrating fluoroscopy with all of that. It was different than what we used to do with a large needle. So that took time, just even the basic steps. And once the mid-year kind of progressed, then we could focus on other things with the interventional fellows. So we did really benefit from that. I never had enough consistency, to be quite honest, because we just didn't have the staffing to have, a single tech assigned to the program for every time I was in the lab. But in general, most of them, there were lots of great folks at MGH who participated and really made it possible to grow.
Perfect. And then what was the hardest thing for you to learn? And obviously Bob is there helping out, you've seen many other people, but what was the hardest thing technically and mentally to master for doing the CTO and complex PCI?
Sure. I think without a doubt, the clinical aspect of taking in a patient electively for something that is higher risk than average PCI is one where one really had to get used to how to know how to counsel and how to know how to deal with complications. And I think that's really what I've learned in the last 5 to 7 years is really how critically important it is to assess these patients and be their primary cardiologist for that short period of time. So every one of our patients that comes in electively has been seen in our office and counseled extensively. And I think as I've shared this anecdote with you, I probably prescribe the most Renexa in all of New England because, our goal is to see if patients can be maximally medically managed for most situations. It's not a prognostic question. It's about a symptom benefit. And, going through that part, you really engender a lot of trust in the relationship. People hear the risks and benefits multiple times. They're counseled multiple times. And I think that is what, over the years, kind of allows me to bring someone in electively where you aren't temporarily destabilizing them. You're giving them a 4% clinical risk of perforation. And you need to make sure your rationale is intact. And when that is intact, then, I think patients understand, families understand if there is a complication, that they were well informed, they really thought about it. So that's been one of the greatest clinical challenges, but this kind of strategy for how we've been able to manage it and handle the serious complications that can occur. Yeah, go ahead.
No, go ahead. I'm sorry, go ahead.
Just to speak on the technical side, I think out of everything we have done, I think probably the two areas that I continue to still grow in is optimal antegrade dissection reentry with controlled stingray optimization, and really focusing on that. My most recent focus has been to really think of this as dissection to stingray time, almost like a door to balloon time, because I have really taken to heart the kind of the world perspective on this, but I don't think I had really kind of a 911 approach to minimizing hematoma, which is clearly the essential aspect of this. But especially when you're teaching and doing other things, really being focused in on aggressive early attempts has been helpful in our success rate. And I think the other part of this has been understanding the patients where epicardial collateral work is indicated and safely possible. Really understanding the frequency of tortuosity and what devices are likely to traverse those carefully. I think that those are still some of the growth areas that I'm working on. I think that probably those are the more technically demanding aspects.
And then how do you feel when you go to cases now? Do you get stressed at all? Do you get anxious? This is like every day, no big deal. How do you mentally feel and approach every case?
Well, every day I know clinically is a big deal for the patients, and that means a lot to me, and that, always keeps me grounded and focused. I think the stress has definitely subsided over the years. There's no question. In the beginning of our time frame, we really formalized the program in 2012, that every case that was coming in, I was way keyed up on. And I think I was also focused on things that were probably not optimal for program growth, which was, what is my success rate? Whereas, at that time, I think there was a lot of focus on you got to hit 90%, and that really, became less of a focus to me over the years. We obviously want excellent outcomes, but it's a really focus of success and MACE reduction. Those are both really important to prioritize, and understanding how to do things in staged procedures, critically important. Choosing a dissection reentry approach and a spam incomplete result is fine, as opposed to having to do something that's high risk in the epicardial collateral and bringing them back for a redo. I think we really learned that in the last 5 years. So these things have helped me become less stressed about the meaning of the procedure technically. The technical part now is much less daunting. I think it's much more structured. After 10 years and doing 1,000 of them, then you feel differently about it. But I'm always hyper motivated for the patient. I really want the best outcome for them, and I think that is what really engages me. Ultimately, is the clinical result, not the technical.
And has your preparation changed over the time? Do you prepare differently now than you would 10 years ago?
I think we really have changed. And again, and probably when Bobby had to move on, what I started doing is I have a written plan for every patient that we are going to do that is pre-sent to our cath lab staff and the techs and nurses in the room, and of course the interventional fellows. And in the last 3 years, we've had a CTO program for fellowship training, and now that is their primary responsibility, is to formulate that plan themselves, and then we review it, and then I will forward it on. And that gives me the chance. I think the reason that we get better and better is there's multiple touch points of film review throughout their process. There's film review with the initial email saying, can you see this patient? Then there's film review in the office, consulting. Then there's film review in our CTO fellow meeting that happens every Thursday. So we see it again. And then there's a film review that probably happens for me over the weekend when I'm doing the final send out to the cath lab. Because I do procedures on Tuesday or Wednesdays, we usually have them sent out by Monday morning. And then there's a final film review that morning. So those 5 film reviews, those multiple touch points by myself and our interventional fellows and the coronary fellow, that really allows us to be highly prepared. We've called for the right equipment to be in place, make sure those neurocoils are restocked, the 125 burrs and lasers and all that stuff is always there for these special cases. And that preparation, I think, is really essential.
And then you've also been a pioneer of the heart team approach. And here's that, I know some of the people are obviously inoperable, the ones that the CTOs have the CTOs, but how does that blend with the preparation for CTOPCI?
Right, that is such an important part of the decision making. I think there are so many times where we, our approach with our surgical colleagues is we are just patient-centered, trying to get the best outcome. We refer to patients to each other all the time. If there's an outside referral for CTOPCI that has surgical type anatomy, I absolutely say, please see my colleague here and understand the perspective of Lima and a high syntax score and what grafting means in that situation. Ultimately, the decision is yours, and if you want to proceed with PCI, you're eligible, but I want you to understand that. And this is in these zones where we have both options still of interest to the surgeon and myself. We will go to a formalized heart team meeting with our extended colleagues in cardiac surgery and interventional cardiology. And, I think that ends up being one of the most patient-centered, helpful discussion points. And in those situations, there are times where people are going to be recommended for surgery. There are going to be times where they're going to be recommended for PCI. And having the support of your community, especially if there's a complication, it's really great. Everyone knows about the case ahead of time. They know your thought process. People realize that you're doing things collaboratively. And so, if there's an emergency case for cardiac surgery or vice versa, people just know that we're part of the same team. It's really great.
Perfect. And speaking of the training of the fellows, that you have an excellent fellowship program, how do you actually choose them? Is there some criteria that something you see in someone and you say this is the person, or how do you choose these people, and do you know how good they're going to be in the lab and in CT or complex PCI?
Yeah, great question. I think no matter what, there's a leap of faith when you do accept someone, because they are doing things that most of the time they've never done before. Every now and then there'll be someone that you've interviewed that really has had true dedicated CTO experience, and that's always an amazing way to kind of start. But we also recognize, our focus in this fellowship is to bring people into it who are not routinely doing it. So, I think we look for we certainly, in the patients, in the fellows that we are evaluating who are interviewing from MGH or the Brigham, we, of course, Kevin or I, because it's a joint fellowship, have had a chance to see those patients those fellows perform in their first year. And, it's really about 3 or 4 months that we have to make that assessment. But that's, of course, great. You understand people's judgment, their hand-eye control, their thought process, how they respond under stress, what's their strategy. And those that we interview outside, we really try to get that sense from them in that brief interview, but also their referees, and speak directly to their mentors and advisors. And then usually in the interview, I'll try to ask them something that is more technically involved. I won't announce it here because then everyone will hear it. But it's usually the same question for all the fellows, and pretty similar takes every year. And that's just a way for me to hear how they're going to approach a multi-step problem, and how they think about the other strategies. What are the contingencies? What are the complications possible? And that is really helpful for me. But I imagine, hand-eye control is something you really have to observe, and that is a leap of faith when we accept patients fellows that we've never worked with.
No, absolutely, and I agree. And again, I think most people have been great, but it's always hard to know who will develop or not. In terms of the research, I must always say that you are the one who is the most consistent, returning on all the papers on CTO that come out. It's amazing. You're the most consistent person in the planet that actually comes back on this. But how are you able to manage, I know you have a lot of high-end imaging research, new catheters, new technologies. How do you still balance this now that you have, a fully developed CTO program, a very advanced high-end research program, and research also on CTO and other complex lesions? How do you balance this in an everyday basis?
Well, listen, I'm just trying to emulate you, friend. I mean, literally, the amount of productivity is inspiring. And, being part of Progress has been a great joy, and what you've done with it is really spectacular and has really influenced so much of the world. It's hard to really do this in a way, but you've pulled so many people together. So I'm always, it's an honor and privilege to be part of it and to help. When I see those manuscripts and I have lovely fellows who are super motivated, it's great to try to help them create the best paper possible. And my contributions are modest, but I enjoy reading every one of them. And it's great to see what's happening. And it's an important priority to me. It's different, of course, than the research focus, which is vascular biology and imaging, and more molecular and cellular. So it's a different part of my brain, but it's just as important to me because it also gives me the chance to reflect on what I'm doing clinically. And you, of course, are fantastic at providing, kind of our outcomes within the whole Progress registry. But seeing what happens on a global level over tens of thousands of patients, understanding what the percentages are for X or Y, it gives you that greater sense of clinical expertise and understanding, which helps your next set of patients.
And then in terms of CT, you've been one of the champions of CT in CTO and otherwise, and that's obviously a different skill. How did that start for you? How did you learn this, and how are you applying it now in your complex PCI practice?
Yeah, thanks. I think that clearly stemmed from being someone who loved imaging and cross-sectional imaging. Before I started doing invasive optical-based work, I did a lot in cardiac MRI. So I was used to kind of tomographic imaging and axial imaging, and I did have a really fantastic partner at MGH. Our radiology department is superb, as is cardiac radiology, and Brian Koshadra and Udo Hoffman have been great colleagues and really helped me kind of start to understand how to analyze CT together and then somewhat independently, not at a clinical level, but enough to help me for procedural planning. And that just took a while of just going through multiple cases and understanding what does an anterior takeoff look like on CT. It's different than what we might think in the cath lab. You just have to flip your mind 90 degrees and become a radiologist that way. And how do you track a right coronary all the way down into the AV groove, into the PDA outflow? How do you track that? And where's the calcium? Where's the occlusion? Those things are super helpful. We definitely have seen that CT does a better job of characterizing CTOs than invasive angiography. And now we have a randomized trial showing that procedurally, pre-procedural use of this improves outcomes. I find it helpful in the most complicated subset of CTOs. I think those that have lots of ambiguity, that are not so calcified that you can see them immediately throughout their entire cast on fluoroscopy. These are ones where it's very valuable to maintain a sense of architecture. In flush occluded ostial right coronary is also very helpful to just know where the aortic entrance is, and if we're going to push something more aggressive retrograde to be able to puncture into the aorta, it's very helpful to kind of have that in place. I think when there's lots of tortuosity, also can be super helpful. When you see knuckles going at right angles in the mid-right coronary, it's nice to know that you're following the center line. So for dissection, it's also helpful that way. And those have been something that now we routinely do. We have CTs increasingly as part of our diagnostic scheme for cardiology, and we can segment those, and it takes about 5-10 minutes to have it up on the screen.
Perfect. So learning everything, including CT and CTO, everything, that's, I guess, a characteristic of people who do this at the high level. So again, this has been phenomenal. But how do you keep in shape for all this? How do you exercise? Do you do anything specific to keep mentally sharp and motivated?
Yeah, thanks. That is such an important thing. The balance is so important in life. I think I'm really grounded by an amazing family. My wife and 3 boys are kind of the joys and the priority in my life. I always want more time with them. The time that we do have, we really make as valuable and as engaged as possible, so that even if your time is never enough with your family, what you do have, you're really connected during that time. It's so important. So that part is a real priority. But I definitely, there's no question with science and a busy clinical practice and family that some of those things I used to kind of think were part of my personality and interest did get kind of pushed aside, and I'm trying to regrow those now as my boys are starting to move on with their lives. 2 are in college and 1 is about to enter. And so I think, exercise, I restarted taking tennis lessons again, which is a great joy. I used to play in high school and intermittently throughout college and life. That's super fun. I think I actually was pretty resistant to lessons. And part of the reason I think I became more receptive is actually going through this process of becoming a CTO operator, where I had to learn from so many other people who were experts, and kind of, shed that preconception that, depending on your age or institution, that you may be differentially valued. Like we recognize that, there are people who are really great because that's what they've applied themselves to. It didn't matter what institution they're at or how old they are, but they have the skills and you can learn from them. So my current coach is a 22-year-old, and he, I'm like, wow, that's pretty amazing. And he's fantastic, and I've clearly gotten better. And that's what I hope my approach to life will be as I, look forward to, tennis. And I think the next step is to apply that to golf, which needs a lot more work.
Good to put goals for down the line. This is perfect. So does golf, won't do golf means you want to retire at some point, or?
I think there obviously that's gonna happen. I do think about that. I'm 54 now, and I think about what are the years going to look like ahead, and I'm constantly just trying to recognize: am I losing my edge? Am I cresting? Am I on my downslope? I know statistically I've got to be on my downslope, but I really am trying to watch for that. Like, where are procedures not going as smoothly as I want? Is that a focus thing? Is that a hand-eye coordination thing? Just kind of reassessing that, periodically, quarterly, and trying to be proactive about any declines and knowing that it's time to move on. That's going to really be a clear focus. But mentally and scientifically, I hope I continue to really enjoy that. The interface of imaging and vascular biology and the idea of imaging coronary inflammation still is a major focus for our lab and what we hope to bring in clinically into the world in the next few years. We have some first-in-human trials planned for that. That's something I think, hopefully my mind will last longer than my hand-eye coordination, so we'll see.
It's good to have multiple avenues for doing things. But what is most exciting for you right now? What excites you the most?
Yeah, it's thanks. I think multiple things. There's obviously on the personal side, seeing my boys grow and have their lives is phenomenal. I think I've been really rejuvenated by our fellowship program and watching our fellows graduate and what they are doing and how they're growing, and having that connection it's different. I've had postdoctoral fellows for decades who are phenomenal and have started to build their scientific careers in their research labs, and that's a great joy. But that hadn't really felt that way in the clinical domain so much, because I had not had such personal responsibility as I do now. And that is just extremely satisfying for multiple reasons. Probably in my own self-interest, I'm going to need one of them in 10 to 20 years, hopefully not less than that. And so building that community is fantastic, but it's really motivating to do that. And I think it's also increasingly, as I age, really still motivating to help an individual patient feel better. I really value, I don't know how you do your follow-up practice, but every single one of our post-PCI CTO patients, I will see, at least have a 15-minute scheduled phone call to understand if they got better. And if they didn't, I have a chance to learn. But it does make me really grounded, and I really enjoy that clinical experience. I really want to see people get better. So those are things that still are super motivating.
And do you have a favorite book or a favorite movie?
What can I say? Last night I forced my boys to watch almost anything by Denzel Washington, but we were watching Remember the Titans, which is still the greatest sports movie as far as I can look at in terms of teamwork and so many different things. We are focusing more and more on being part of going to concerts, which span a broad range. I think music has really been an important part of our family life as well. And I listen to a lot of alternative music. I was a DJ in college. I try to bring that blend in, and we have classical music interests and so forth. So we have a range of things happening in the house.
Sounds perfect. Looks like you have your hands full. So Farouc, if you had to summarize, if people ask you for some pearls of advice, some pearls of wisdom for people who are starting now, your fellows or people who are starting to learn CTO and complex, what would you say are the 2-3 key things that they could use to follow their pathway to becoming experts?
Yep, I think the first thing is to be patient-centered and patient-grounded, to really understand that you're their advocate and their protector in terms of moving forward with complex procedures. And then secondly, I think, is to really focus on how to build your community within your own lab and externally, knowing how to improve systematically and to handle complications and setbacks is always handled better with an established community. And I think the third thing is really recognizing, as we've seen on the Dunning-Kruger curve, is to realize that most of us start off in the very beginning of that curve. And to be humble in this process, to realize it's going to take time, and to be systematic again about building your education from cases and experts to complement the work that you're doing. It's so important to be all in and to recognize that it is a time-based process and that one can really succeed, but just to be systematic and focused and grounded and connected will be the way forward.
Perfect. I think this summarizes the field excellent, and these are great skills for everyone, including the people who are into this for a while. So Farouc, thank you. Thanks again so much. Tremendous knowledge, tremendous pearls of wisdom. Thanks again for taking the time. Thanks for all the work putting up with us over all those years, and excited to keep working on you for many more to come.
Absolute pleasure to be here, Manas, and congratulations on everything that you've accomplished as well.
Thank you for listening to the Sensei podcast.